Okay, good morning. We're going to start with this infiltration scale. So I'm going to actually put this on a slide as well. So you can see that there's a scale from 0 to 4 for the infiltration scale. And the infiltration scale is when the IV is either running or it's not running. So the idea here is that if you have anything other than a 0, you have to stop your infusion and resite your IV if required. And if grade 3 or 4, you have to, especially if a medication is running, leave the cannula in situ and consult the physician for further treatment before removing the IV cannula. Because what we do know is with grade 3 and 4, if the medication is running, it can cause a lot of irritation to the tissues. And I'm going to just scan over here to a picture of what it looks like with blisters and swelling and some damage. Back over here. Sorry, I hope I'm not making anybody nauseated here. Medications can be infused to mitigate that effect. So that's the first thing, is about an infiltration scale. So you'll be asked to grade your IV on the infiltration scale, and you will be asked to also grade it on a phlebitis scale. So phlebitis is inflammation. So again, it's 0 to 4 with either no symptoms, erythema at access site, pain at access site with erythema or edema, pain with erythema, edema, streak formation, palpable venous cord, and obviously the worst case scenario is streak formation, palpable venous cord, and purulent drainage. So if you have a grade 1, and I'm going to show you what a grade 1 looks like right now. We're just going to scan over here. This is a grade 1. This is an IV that has no pain, flushes easily, good blood return, but you can see that there is erythema. So this type of IV needs to be monitored every hour, because it could definitely change and become this one, which is painful, even if it flushes easily or not, and the vein feels quite hard and palpable. So I'm just going to come back over here. Pardon this scanning. So grade 1, reassess every hour. Stage 2, 3, and 4, it has to be recited if required. And grade 3 and 4, notify physician, consider warm or cold packs, and elevate. So the other two things is, if you have an IV with an infiltration scale of grade 3 or 4, or a phlebitis scale of grade 3 and 4, this requires an incident report. Okay, now the other thing that we probably haven't done is remember to build a dynamic grouping for each IV site. And I'm not 100% sure how to do that, but I will find out and send you some sort of information on that. But this is kind of what it looks like. You have angioneedle left dorsal vein foot, so this would be a pediatric one. And then what will come up, and this scale will start the end of April, is a phlebitis scale and an infiltration scale. And your little scale will pop up. So the other thing is that you need to document every 4 hours if the patient has a continuous infusion, of which oxytocin, obviously, if you're running it, will be that. And the other thing is, we just want to look at some IV sites here. So this is kind of like the gold standard of what an IV should look like. There's no infiltration, it's flushing easily, it's running well, good blood return, and there's no phlebitis. It's nice and warm. Sorry, feels normal to touch, no pain, no swelling or anything like that. We looked at the one with the erythema, even if there is no pain, flushing easily, good blood return. We would say that this has an infiltration on our scale of 0. It's running well because we have flushing easily and good blood return, but we would give it a grade 1 for our phlebitis scale. And then we're going to move down here, and we're going to look at this one. And this one says it's painful, but it flushes with blood return, and the vein feels hard. So if we go back, and I will make sure you have a copy of the infiltration scale and the phlebitis scale, this one might be an infiltration scale of 0 because it's flushing well, but we certainly have phlebitis here. We've got a phlebitis with pain, we've got a palpable cord, so we have a grade 3. So this one needs to be removed, but we also need to notify the physician and do an incident report. And this is the worst case scenario. And this one definitely needs to be left in because if it was a medication running, but we also need to notify the physician and do an incident report. So the thing is about these IVs, even lactated ringers or, you know, a D5W or something, if it goes interstitial or there's infiltration, it can damage the tissue quite a bit. So we really want to make sure that we are assessing our IVs when we have a continuous infusion. So it would be oxytocin and mag sulfate, anything like that that's running through the pump, that we are actually looking at the IV every hour, and the minimum amount of time that you're documenting is Q4. Now, for the postpartum patients, I'm still working it out with the nurses. I think we're going to be trying to eyeball the IVs Q hourly when they have their oxytocin going and documenting Q4. Anyway, that's all I have to say about this. It is a short video, and I will post it for you, and I will get some slides for you as well.